Can y'all hear me okay?
Yes, sir.
All right, I am setting up. There we go. I'm trying to get my audio, my video adjusted here. I think I've got it all. There, let me start the video. There. All right. How are y'all tonight?
Great.
Wonderful.
Good.
I was teaching adult and geriatric psychopathology just before you guys, and only had one student show up. So I'm glad to see that I've got more than one of y'all here tonight.
I appreciate you doing
Oh, absolutely. Honestly, this is the most enjoyable part of teaching is actually teaching. I'm going to pull up our PowerPoint slide, and we're going to give everybody just a couple more minutes to see who else comes in before I kind of jump in. But I'm going to try to get this set up so I can split my screen. There we go. Perfect. Can y'all see that okay?
Yep.
Yes.
Perfect. And do you still see me on like a video on your side?
Yes, a little video. Yeah, and
Good.
the three names.
Just want to make sure so I'm not like picking my nose or anything,
Okay.
thinking that y'all can't see me. Nobody laughed at my joke there, but that's all right.
Sorry,
I did, but it was
trying to get
muted.
set up.
Mine was muted
No
too.
worries. No
I'm
worries.
struggling to get my video going here.
I'm a dad, so I'm used to people not laughing at me. No, looking forward to getting to meet all you guys this semester and
I need space.
getting past this the holiday break here, because it's strange to start class and then stop and then take like a break and then come back, and it's like you have to kind of start all over whenever we get back, but that's okay. Because we all need a break, and hopefully you guys are getting good breaks with your holidays here. So I think this would let me there. And
on his way to be home, huh?
there. All right. Okay. I think I'm good now. I have a Mac at home that I use, and I have a PC at work. And so it's like two different languages trying to figure out how the same application works. But well, we will go ahead and get going so that we're not just sitting here awkwardly listen to each other talk. But for those who don't know me, I'm Dr. Armstrong, and I am your professor for this term. And I love this class because this is I would say, in my opinion, probably a little bit biased though, the bread and butter of being a counselor is, even if it's not professional counseling, it's school counseling, or LMFT or whatever, it is the core foundation of your scope of practice. is to understand the diagnostics and the underlying, I would say, pathophysiology behind mental illness and abnormal behavior, and especially as it relates to diagnostics. I recognize that for this class, I probably have quite a few school counselors who, at this point in time, at least in Texas, won't be making diagnoses of any mental illness. But I also want to encourage you, if that is you, that the reality is the way the liability stuff is working out, there's a really good chance that school counselors are going to have in the future their own independent license at some point, because I can promise you the attorneys for school districts would love to separate the school's liability as it relates to the student's mental health as much as possible. And so I wouldn't be surprised to see that happen at some point in Texas. So what you're learning now might not be applicable immediately in that setting, but it will be applicable as it relates to conceptualizing this stuff, helping those students, and then also probably down the road. So that's my one caveat with everything. For everybody else, this is absolutely the foundation for the vast majority of what you will be doing clinically. Even if you plan not to diagnose, which is completely okay, and that's your prerogative, even if you plan not to diagnose, you still need to understand that the brain plays, I would say, the central or main role in causing mental illness and how that pertains to the practice of counseling and treatment planning and so forth, because you will have a license someday, and in order to provide treatment, which is any form of psychotherapy, you have to have a rationale for treatment, which is going to have to include, at least to some degree, some level of diagnostics. So, is anybody in here school counselor? Everybody's LPC or LMFT?
Yes.
LPC.
LPC for
Awesome.
me as well.
Okay. So, and Audra, you are?
LPC.
Okay, so we've got, y'all three are all awesome. So everybody's LPC here. Perfect. Where are y'all at in your programs? So there's only 3 of us or 4 of us here. We'll start with you, Karina.
Yes. My name is Karina Marino, and I'm about halfway through the program, or halfway to pre-practicum, I should say. Yeah.
Congratulations.
Thank you.
It's like the light gets brighter, then all of a sudden you realize you've been outside for like an hour, and you're like, I'm not ready to be out here yet, but it comes quickly. Yeah. Yeah. How about you, Sarah?
I have 3 more classes and then I start pre-prac.
Awesome.
So yeah, that'll be in June.
Sarah, did I just email you? No. There's another Sarah. Never mind.
There's so many Sarahs at Amberton.
There's a bunch of Sarahs. Yep.
Mm-hmm.
And a bunch of Johns. There's got to be at least 11 Johns that I have in like emails that will email me, and I'll email them back. It's like, hey, I forgot to, like, I didn't email you. It's like, oh, wrong John, I guess. Yeah. Well, congrats as well. And how about you, Audra?
Yes, I've finished about a third of the program. This will be my 4th session here at Amberton.
Yeah.
So I'm really enjoying it. Career change for me, and I'm excited about it.
That's awesome. Well, congrats on that too, because here's the thing is, this is what grad school felt like to me. Maybe it's unique to me, but it's like you start and you're like, oh, I'm so excited. I don't know, like I've got so much to learn. You take like 2 or 3 classes, and all of a sudden people start talking about you finishing. And you're like, what? Like, no, I need more. Like, and there's like this like nervousness or anxiousness of like not having enough yet and not being ready. If I can encourage you, that's completely normal. And at the end of all this thing, even when you get your license, you're gonna be like, they really think I know what I'm doing. That's just how it kind of feels. And I've been practicing. I've been licensed now for about 10 years, and I guess clinically been working for, gosh, 16, 17 years. And it is basically a feeling that never goes away. And I know way more than I used to know. And I feel confident in what I know, but I also still have a hesitation of like, gosh, this is a unique person in front of me with a very unique story. And I'm telling you, nothing ever looks exactly the same. And so, but it keeps you on your toes. And I still have to daily Google like, medication names and all kinds of stuff, just because people come in and they'll tell you, well, I've been diagnosed with this random rare genetic thing. And like, I don't know what that is. So I've got to, we all have to continue learning. So don't worry. You got the rest of your life to be in school. Unfortunately, you can't defer student loans for continuing education. But you guys probably don't have to worry about that too much with Amberton, because we are pretty affordable here. So my goal tonight is I want to help you guys learn the foundational information that you need from a neurobiology standpoint, so that when you read through the DSM-5 as a method to treat your insomnia, you will understand. Thank you for chuckling at that joke, but you will be able to more efficiently understand what they're talking about and why they're talking about what they're talking about as it pertains to the biology, because that's the psychiatry perspective, and that's the medical model, and it's not going to go away, and hopefully it doesn't, because I'll be out of a job if it does. But if you can understand it from that standpoint, it'll really help you kind of sort through the diagnostics much more efficiently, because you'll start to realize that big book that we have, the DSM-5 TR now, is a work in progress, and you're going to start identifying things about it that are quite limited in how it categorizes mental illness. So the goal for tonight would be to cover some of the biology behind it. There's only 3 of y'all, so I'm also open to just kind of jumping and having more of a discussion rather than me just lecturing. But I definitely do want to make sure I'm covering the biology behind all these things, so that y'all will have that to as a backdrop for the remainder of the semester. So before we do that, any questions about the tests or exams or the quizzes, anything like that?
Not so far, not for me.
Okay. All right. I think for y'all's class, your quiz 1 was just 1 question. Was that right?
Yep.
Yep. Good. I had a student email me the other day and said that they studied a lot for it. They clearly haven't clicked on it yet. So, or maybe they had, and what they meant, they read the syllabus. So let's talk about, not Bruno, that's the song that jumps in my mind. Let's talk about first how to make a diagnosis and why it's important. So here's the thing. when we make a diagnosis of any mental illness, it is not the same thing as like a physician diagnosing a broken arm. What's the difference between like doing an x-ray, looking at somebody's arm, showing like a broken arm versus diagnosing somebody with depression? What's the difference there?
It's not quite as lenient, I think. It's a little bit more flexible, where you see certain behaviors and maybe it can fit here, but it can also fit over here. And it can be more than one. Like for a broken arm, either you have it broken or you don't.
Yeah.
Here is a little bit more of some gray areas at times.
Absolutely. And what we call that, or what it's called, not what we call it, but what it's called in medicine is a clinical diagnosis or a working diagnosis. A clinical diagnosis is what we do, where it is based on, it's our best guess based on a constellation of symptoms that we will absolutely continue to refine as we gather more information along the way, as compared to a formal diagnosis of like, well, you've got a broken arm. You don't have to be a doctor to look at the x-ray and say, well, that's a broken arm. There's no argument that's what it is. What we do are clinical diagnoses. And so I'm telling you that because there's going to feel like there's a pressure to just be 100% precise and right the first time you make a diagnosis. And though we want to be as accurate as possible, and that's our goal, it's also okay if you know in the back of your mind that I'm going to make a diagnosis as best as I can, but recognize that it's probably not going to be as precise as it will be 10 sessions in working with this patient. Okay. Obviously, from a counseling standpoint, there's a history of our profession pushing back against diagnostic labels, depending on the theory. And I used to be in that camp, and there's nothing wrong if you're in that camp now, but I used to be in that camp, and I've not gradually, I would say pretty swiftly shifted into being okay with making a diagnosis, because I see it as a therapeutic intervention in and of itself. Making an accurate diagnosis, communicating and educating your clients or patients. I like calling them patients because we're not selling real estate, but communicating to them what this is, providing them with a conceptual framework, is very therapeutic and can be done therapeutically, to the extent that the pros almost always outweigh the cons as it relates to the ethics of diagnostics. I get a lot of, I have professional colleagues that will argue with me on that, and that's okay. You just need to, at some point, land somewhere, because that will help you recognize how your bias affects your approach to counseling. I land on the diagnostic side because I see these things as biological illnesses that, of course, there are psychological factors at play, but if we didn't have a brain, you wouldn't have any of these things, right? But at the other side is, it's important to know with psychiatric illness, it takes away from the sense of shame that is associated with most of these diagnoses, and therefore decreases the stigma. Because nobody out there on the planet right now, like if it were in your scope of practice, we would have no argument about diagnosing high blood pressure, right? Nobody's out there like, oh, I don't want to put that label on people. I don't want to put the high blood pressure label on people. Nobody says that. Nobody's worried about having a high blood pressure label. But people talk about that with depression as if it's different, and it's not. It's biology. Here's another good way of looking at it is seizures. None of us would have a problem making that label for somebody because nobody walks around feeling any kind of shame to say, oh, I've got seizures. Yeah, this is biology. Or migraines. Nobody has a problem telling random strangers at the gas station that they had migraines. We're talking about the medication they take for migraines. But we can't do it for depression or anxiety or bipolar, ADHD. Yeah. And that's strange that there's like this separate perspective that we have to kind of fight against there. And I'm very much about destigmatizing this stuff. And the more we can help patients see it from a biological standpoint, it feels less like it's their fault. It's still their responsibility, but it's not their fault. I don't know about you, and I won't ever ask a student to share about their own personal life, but so I have recurring depression, I have OCD, and I have ADHD. As a kiddo, I used to pluck my eyebrows out, and you'll learn about that, and it's called trichotillomania. I'll still do it if I'm tired enough. And I recognize I'm doing it and stop now, but it's a form of OCD, and I have intrusive thoughts with that stuff. And, long story short, through my own journey on that front, I've never had one day in my life where I woke up, I was like, you know what? My life's too easy. I think I'm gonna have some OCD, maybe some depression, probably some ADHD too, because that's kind of cool right now. I've never had that day that I've woken up and said that. If anything, I would love to get rid of it all. Certainly so I wouldn't have to take medication. But it is my responsibility, though, to not allow those things to negatively affect my life to cause dysfunction if I want to live a non-dysfunctional life, or as close as I can. And so there's a fear there that if we make diagnoses, that patients will use that as an excuse not to take responsibility. But it wouldn't matter if we're diagnosing high blood pressure. It's still that patient's responsibility to take care of themselves. So, all right. With all that said, as it relates to child and adolescent neurodevelopment, because this is the unique perspective here for this class, even more so than adults, children and adolescents have a lot more complicated aspect to conceptualize diagnostics because they are a moving target. And if you remember nothing else about this entire class, or from me at all, I want you to remember this, is that the frontal lobe and its underlying axonal connections, or the connections that spread throughout the brain from the frontal lobe, and its neurotransmitter system, which is primarily norepinephrine and dopamine, that whole system is the most sensitive part of the brain. So anytime anything happens to the brain, whether it's prenatally or like at birth, those first few years, or up until age 25 or so, if anything happens to the body or the brain, the frontal lobe is the most likely part to be affected as compared to the rest of the brain. The answer of why is because the frontal lobe doesn't stop developing until it's about 25. What that means is that all the functions of the frontal lobe aren't fully developed until then. And so if anything from a medically or trauma, stress, substances, injuries, things like that, disease, anything that affects the body I would say the body or the mind psychologically is most likely to affect the frontal lobe. Does that mean everything causes long-term changes? Probably, but doesn't mean that everything is long-term measurable changes. As it relates to psychiatric illness in children and adolescents, what we know is that most of these diagnoses, if not all of them, affect the frontal lobe in such a way that probably causes a different developmental trajectory for executive functioning, which is what the frontal lobe does. In other words, they were on this path as a kiddo of, arriving someday at like this perfect executive functioning, like trajectory, like a perfect adulthood, adult level executive functioning. And then this psychiatric illness comes along, whatever causes it, changes that course and probably reduces their long-term trajectory for executive functioning. Now, with what we do as counselors, the good news is that the frontal lobe is the most plastic during neurodevelopment compared to the rest of a person's life. And any intervention or treatment you do during childhood is about 10 times more effective and more efficient at helping for symptom resolution and long-term change as compared to working with adults. And that's the coolest thing ever, because literally we're in the business of healing these kiddos' brains and completely changing their life. And you can do it pretty quickly too, as compared to working with adults. The last platform I have, I promise I'll stop preaching. I feel like I'm preaching. I'm not a preacher, but it just feels like I'm preaching. My last passion here with kiddos is this. As counselors working with kids, and it doesn't matter what the diagnosis is, and it wouldn't even matter if they had a diagnosis or not, their frontal lobes lack the neurological capacity to take what they learn in therapy and independently apply it in real world situations, and certainly not to the same level that an adult would be able to do that. Does that mean that counseling or therapy isn't helpful for kids? No. What it means is that we also need to teach that child's system how to prompt, remind, and self-monitor that kiddo so that that kid can take what they've learned in therapy and apply it when they need to. I'll give you an example. In adults with like panic attacks, we often teach them like deep breathing techniques, knowing that if I teach them that and we practice it in therapy, they're going to be able to independently go out to the real world, and while they're driving, having a panic attack, pull over, recognize they're having a panic attack, remember that we've been working on these skills, and independently practice it, and hopefully that'll be effective for them. But a kid doesn't have the same self-monitoring capacity to, one, be aware that they're even having a panic attack when they're having one, and then two, be able to say, okay, even though I'm not in therapy right now, I can still use that same skill now, even though it's just a little bit different. Does that make sense? Yeah. I'm really passionate about that because I get a lot of parents with these kiddos that come in and say, oh, we tried play therapy, or we tried, counseling for little Johnny or little Susie, whatever, and it didn't work. And when I ask about more information, what kind of therapy was it? What did they do? They'll say, oh yeah, we took them there once a week and just kind of dropped them off, and then never really talked to the counselor. That might work for an adult. Well, first of all, just so you know, it's not all, you can't really rely on adults either. We're not all that great as adults generalizing things that we learn in therapy, but it's not going to work for kids. The reason why it didn't work for those kiddos is because that counselor never brought the parents in there and taught the parents what you were taught in grad school, so that the parents can continue molding and shaping that frontal lobe the rest of the hours out of the week, because all you get is that 1 hour. Okay. All right. Those things I'm passionate about. Again, if you don't remember anything else, remember that stuff. And I'll be happy, although your grade might not be happy because you probably need to remember more stuff than that. But I'll be happy personally if that matters to you. Let's talk real quick about a couple things. By the way, if you hear my kids yelling and screaming, I've got a 5-year-old and an 8-year-old. And I don't know if y'all have kids, but this is about like this is like the witching hour between now and 7:30. It's like our wheels were on the car, but like they just start like one by one, the wheels start coming off. So because it's almost dinner time, almost bedtime. But I do want to talk about 2 important times neurodevelopmentally that matter greatly as it relates to how we conceptualize mental illness in kids and adolescents. That is the terrible 2s and 3s, right? And the teens. And not just the teens, actually pre-adolescence through adolescence. We all know, and I think you guys were required to take lifespan development before this, but if you weren't, don't worry, because we kind of covered some of the same stuff. But bottom line is, during those 2 times in life, we've got a brain that has decided, you know what, I'm tired of the status quo. Let's shake things up a bit. We need to gain some skills because something big is coming our way. Now, starting with the 2s and 3s, sometimes 4s and 5s and 6s, we have a brain that literally is wiring itself based on how it can get the environment to respond to its shenanigans. And I'll explain that. But we call it the terrible 2s and 3s, right? Because it seems like emotional regulation just goes out the window. You know, I remember my son following me around room to room after I'd said he couldn't like have I think it was like around Halloween, that he couldn't have sucker or something. He was just following me around room to room. And every time I looked at him, he would just like collapse on the floor and just was like bawling, squalling, crying, right? And like, as you know, as parents, we're trying to, we're trying to be comforting, but not reinforce that kind of behavior, because what I'm doing is I'm trying to teach him how to regulate or self-soothe. That's a part of neurodevelopment, is learning how to do that. I do that, or what prompts me to teach that is his own brain causing him to be emotionally dysregulated during that time. It's a survival mechanism, because the brain, the frontal lobe's like, all right, we've gained some motor skills. We've got some words now. What else do we need? Oh, we need to be able to tolerate stress. Well, how do you do that? I don't know how to do that. So the frontal lobe's like, okay, well, let's throw some tantrums, make mom and dad teach me how to self-soothe, how to regulate. That's literally why we've got the terrible 2s and 3s. So you can imagine that disruption, neglect, trauma, stress during that time of development, how that might affect somebody for the rest of their life. Because after that, those terrible 2s and 3s, sometimes 4s, after that time, we've kind of moved past an important stage where if we didn't get those skills built, it's not that we can't still learn some, it's just that we can't learn it as well or as efficiently as what we could have. And so when you see an 11-year-old kiddo that has a history of emotional regulation difficulties, a lot of times you can pinpoint it back to what was going on during that time, during those 2s, 3s, and 4s. Did the frontal lobe get what it needed? And it's never perfect, but did it get enough? Is that making sense? All right, and then the same thing happens with teens. Everybody talks about teens, by the way, and I really hate that there's like a stigma, like, or there's like this like chuckle that us adults have, like, oh, teens, with like their, their woe is me emotional regulation stuff. It's not, first of all, we were all there at one point in time, and we would have hated it if adults, said that kind of stuff about us. Two, the cohort generation right now that are teens, I can promise you, are going to be the toughest generation there has ever been, because I'm telling you, no other generation has gone through the hardest time of life, which is what it is neurodevelopmentally, on top of having all the social media pressure that most of us have never had to face. And then on top of being in a pandemic right in the middle of all of it, watching adults fall apart. And so every time I meet a teen, I literally tell them, like, listen, I'm here to help you because I've got a huge heart for you, because you are going through some stuff and you've been through some stuff. And I don't have all the answers, but I see it as, if we can help you get through this stage right now, y'all are going to be the toughest people that have ever walked this planet before, psychologically. But teens, their brain, their frontal lobe says, all right, we've got some social skills now. We're able to kind of think about the future. Whoa, the future. That's what the frontal lobe says. The future, that means I'm not going to have mom and dad for forever. And I'm going to have to get a job. What? I'm going to have to get married, or maybe get married or have kids or have all these responsibilities. I don't know how to do any of that stuff. And so what does it do? The frontal lobe, again, starts to cause that pre-adolescent and that adolescent to behave in ways to elicit its caretakers to teach it how to be an adult. And it does so by being, by pushing back against them in every way possible, creating arguments. I love it because it's like, I think about, I don't have a teen yet. I don't think my kids are ever going to get there because they're stuck at age 5 and 8, which is great because I don't want them to grow up. But everybody else's kids grow up, and I love it because it reminds me of, like, again, this was my daughter. I remember she was like 5 and I couldn't figure out what she wanted to eat. She was like, I was like, do you want, these noodles? Do you want, whatever it was, applesauce? And she was like, no. I was like, fine, you just want chocolate cake. And she was like, no. And I know she loves chocolate cake, but she was just saying no, just to say no. And that's what teens do. Teens do the same thing, just on a higher level with their parents, especially. It doesn't matter what their parents are doing. They're trying to help them. It's like, hey, listen, I just don't think it's a great idea for you to be out at 1 a.m. on Friday night. Right? Because that's just, I don't want to, as an adult, I want to be out at 1 a.m. Friday night, whatever. But they're going to push back against that stuff, not because they've got an attitude problem or anything like that, literally in an effort to get the parents or the caretakers to teach it why that's a good judgment call, because the frontal lobe doesn't have that built in yet. And so you can imagine, if we've got disruption during that time, what that might lead to in adulthood. Immaturity, how we would, non-clinically define it. When you see adults, you're like, man, maybe Erickson was right. People really can get stuck in these developmental periods emotionally, right? That's what we're describing. All right. The last thing, as it relates to the unique child and adolescent piece, is that when we have a neurodevelopmental disorder present, or I'm sorry, when there's any psychiatric illness present, there's a good chance that we also have a comorbidity or a co-occurring diagnosis. That's another way of saying comorbidity. A co-occurring diagnosis of a neurodevelopmental disorder. Does that mean that every kid with depression has ADHD or a learning disability or autism or anything like that? No, but it does increase their chance of developing that stuff, simply because we know that psychiatric illness equates to stress, and chronic stress through childhood disrupts the development of the frontal lobe, which in turn produces neurodevelopmental disorders. Okay? I'll say it again, and here's kind of where I land, and we'll talk more about this when we talk about neurodevelopmental disorders. That's probably going to happen next time when we really get into the meat of it, but let me say this is, I get a lot of referrals from like counselors and other like psychiatrists, like to test to see, is this trauma in this kiddo or is this ADHD? And I'll tell you, in most cases, not all, but in most, it's both. And the reason why is because we know, because the frontal lobe is the most sensitive part of the brain and that it's still under development, chronic stress and the brain don't mix very well, especially as it relates to the dopamine and norepinephrine system. For example, does anybody know what another word for noradrenaline is? Norepinephrine. I'm teaching, Bubba. I'll be there in just a minute. My son wants me to play a video game with him. But norepinephrine is another word for noradrenaline. Adrenaline is what your body produces in response to stress, particularly acute stress, right? Not like acute stress, like look how cute it is. Like, I mean, like acute, like happening in the here and now, right? And we want adrenaline to happen in the here and now if we were being chased by a lion. Everybody would agree with that, right? We don't want it to happen tomorrow if we're being chased right now. We need it, but we also don't need it happening tomorrow if we got away. And that's the problem. Our brain has a hard time shutting that system down once it turns it on. And uniquely to humans, we have the ability to think about the future, which produces, we can make our own fight or flight response turn on. That's unique. Other animals don't have the same cognitive capacity like that to when they go to sleep at night, animals don't have insomnia. they don't have anxiety induced insomnia because they don't think about, okay, well, am I going to turn that assignment in on time, or what's my retirement account looking like these days? They don't have that capacity. That chronic stress, though, degrades biologically the connections of that whole frontal lobe system. So when that happens to a high severity or to a chronic enough nature, like over a period of time, that degradation can result in what appears to be ADHD, and really is best defined as ADHD, because there might not be any going back, depending on how long it's happened for that kiddo or how severe it was. All right. I'll pause this right there. We have anybody have questions so far? I'll take this. Or go ahead.
Okay. So what I understood from your last statement is that if those connections in the biological system get degraded enough because of continuous stress, then there is no coming back. Is that correct?
The older a kiddo is, the harder it is for any degradation to be repaired. And that's true for everybody. So like the older you get, the harder healing becomes in the brain. And it might be such that, well, I'll give you an example. 33% or approximately 30 something percent of all kids with ADHD grow out of it. And we know that probably treatment, and especially with the right type of medication, and we'll talk about that. Don't worry if that makes you upset. We'll talk about it. But with the right medication, probably a higher level of kiddos grow out of it. But if you're an adult and you have ADHD, guess what? You're never growing out of that thing. You're stuck with it the rest of your life. The reason why is because that system is done developing. You can't go back in time neurodevelopmentally and teach your brain to produce more dopamine receptors in the same way it learned to do that from conception until about age 20 to 25. Does that make sense?
Mm-hmm.
Yeah.
Thank you.
And so the older a kid gets, the more chronically they've had a symptom or a diagnosis, the harder it is to treat. And it's not that you can't improve stuff, you can. It's just that if you're working with depression with a 4-year-old, for example, you've got a better prognosis for that 4-year-old responding to therapy than you would a 17-year-old who's had depression multiple times throughout their life so far.
May I ask you one more question?
Sure.
So as a mom, I have this concern over my kid all the time. And I know we can't do therapy on my kid particularly, but generally speaking, would you say that for a child with ADHD, the length of time that they play video games that tend to, those that kind of excite them and they need to have a prompt response and they go left and right and go and come, and would you think that aggravates the physical part of what's causing the ADHD symptoms?
So I'm real passionate about that in particular because I am a gamer myself.
Mm-hmm.
So I don't know if I told you guys I have ADHD.
Yes.
I don't know if I told you that. Yeah.
Mm-hmm.
Okay.
Yep.
So this is where I would say the science has us right now. It's not just my opinion. This is the science. There's two camps. There's the American Pediatric Association consensus opinion, where they all had like a conference and they all got together and they said, hey, what do y'all think about like video games and stuff like that, like watching too much TV and stuff? And then they all said, well, we don't think it's a good idea. We don't think it's good for the brain. And they said, okay, well, let's write that up and then tell the world our opinion. Tell them it came from us. That's what they did. That's their consensus. It is not based on science. Because the science is that there's no evidence as of yet to suggest that the video games are exacerbating or increasing the prevalence of ADHD or any psychiatric illness for that matter. And it makes sense because ADHD isn't a set of symptoms that are conditioned. They are symptoms that are built into the brain neurologically that cause that person to seek out things like video games.
Mm-hmm.
And it's the hyper focusing that is the challenge with as it relates to ADHD. And so it's not that I'm saying, hey, just let them play as much as possible. But I get parents asking me a lot of questions like, well, should they play at all? It's like, well, to be honest with you, the science doesn't have anything, to say like negatively about it causing it or making it worse. But I'll just tell you that it makes sense, or just intuitively to me, we need to make sure kids are exercising and moving their bodies enough,
Mm-hmm.
not just their minds. We also need to make sure that they're safe and not being, like exposed to predatory, crazy behavior, because there's a lot of that in video games. We also need to make sure they're talking to other kiddos and developing relationships. And that we're using what is clearly a reinforcing thing for them, which is video games, to help train their executive functions. We're using it from a behavioral, like operant conditioning standpoint. In other words, we are intentionally using that as a reinforcer for helping improve their executive functions. Because otherwise, like, it's just like anything else. I mean, it really was the same like cultural phenomenon that we have with TV back in the day. And then before that, it was the radio. And so it's never good for a kid to not exercise, not sleep, not, challenge their mind in other ways, or relate with others socially. And if video games are interfering with that, then yeah, they need to back off of it.
Mm-hmm.
We're getting pretty close here with wrapping up, but I do want to highlight a couple things. And I want to jump into talking about the biology just to kind of start that process right there. I know we've kind of already been talking about it, but you need to know that the brain develops itself back to front, right?
Mm-hmm.
And so the first thing to come online as a neonate, as an infant, the first month or so, first few weeks really, is visual spatial processing, which is the occipital lobe. When I say come online, you've got the gray matter. You've got too much gray matter you've got too many brain cells, but what you don't have are all the solidified connections between the brain, like between the parts of the brain. Those come with experience. That's what environment input shapes. It's not the shaping of the outside of the brain, it's shaping literally the connections. And so the occipital lobe turns on first and learns how to like recognize things and like spatial like perception, especially faces as it relates to attachment. Then the next stage is the sensory motor stage, where the parietal lobe and part of the frontal lobe start working together, learning like I can move my body in space, and where am I in space? What is hearing? What is sight? What's sounds and taste? And then about 2 to 5 or so, language pops on board. That's the temporal lobes. And if you think about it this way, and this is a really interesting concept as it relates to what we do professionally, when a child has a language delay, they also are going to have emotional regulation difficulties. The reason being is that the part of the brain that deals with expressive language, that's your left dorsolateral prefrontal area, right there. That part of the brain is directly connected to the amygdala, which is the fight or flight or fear response center of the brain. When you talk, in order to talk, that part of the brain has to turn off the fight or flight center of the brain. If you have difficulty talking, not just speaking, like the production of speech, but I'm saying translating your thoughts into words. If a child cannot do that, that means biologically they also cannot regulate their emotions at the same capacity that a kid with language can. And it makes sense too. If you think about normal development, like an age, 18 months, it's kind of really when the terrific twos start. But an 18-month-old is a lot more challenging to help them like self-soothe than like a 3-year-old is. And the reason why is because a 3-year-old has more words. Also, what's really kind of cool about that developmental time frame is you don't remember much about yourself, if anything at all. In other words, you have what's called childhood amnesia, which is a real thing, until language happens. Until language comes on, you don't have an autobiographical memory. You don't have a concept of I am me. I remember, you might be able to remember way back until you're about 2. That's probably the earliest you can ever do it. And that might have been because language is pretty precocious with you. But it's directly tied to language development. And you'll notice that most kiddos who have difficulty regulating their emotions, and even adults for that matter, often have subtle difficulties or differences with how their language functioning is compared to everybody else's. That's why talk therapy works, though, by the way. That's why when somebody is experiencing a psychotic episode, or if they're having like a trauma response or reliving like a trauma in the here and now, the more you can get them to talk during that, the more grounded they're going to be and the more under control emotionally they will be. I think that's the coolest thing ever, because none of us had to like practice language coming on board. Like, it's built into our brain. Even if we put a kid, a baby on an island and somehow could take care of it, and there was nobody around, guess what? Their brain would still develop a language for them. Nobody else would know what words were or what kind of these sounds meant, but they would develop their own language because it's built into the brain in order for that brain to regulate its emotions enough to continue learning into adulthood. That's the whole purpose of it. Like, the sole foundation of language being built in is emotional regulation. That's the coolest thing ever to me. Then the rest of our life, we've got a frontal lobe. This is like, all right, what now? And it's being shaped primarily not by anything built into it, but literally by what it gets from the environment as it relates to planning, or as it relates to developing these skills: planning, prioritizing, impulse control, mental flexibility, emotional regulation, social skills, social judgment, morality, abstract reasoning, self-monitoring, task monitoring. All of those functions of the frontal lobe, those have to be taught to it. from the environment. And as I mentioned earlier, as a therapist, you get 1 hour with that kid. That's 1 hour that you're working with the frontal lobe compared to the rest of the hours they're doing whatever else they're doing. As it relates to those video games, by the way, that's an important fact because, again, if we're not getting a balanced diet, so to speak, and we're only getting video games, we're probably not getting all the psychological nutrients or the systemic nutrients that the frontal lobe needs for that brain. All right. As it relates to the brain, we've got the outside of the brain is the gray matter, right? On the inside of the brain is the white matter. The white matter are the wires. The gray matter are literally the little computers, little tiny computer systems. Problem, though, is that, well, not the problem, it's actually a good thing. Each of those computers, each of the neurons have wires, but those wires don't directly connect to the other computers. They go really close to them, but they don't have a direct connection. And so what that gives the brain is the ability to constantly be dynamic and changing and molding itself and rewiring itself constantly for the rest of that person's life. But it also means that we have to have some way, if one computer wants to talk to another one, to communicate to each other. And that's where neurotransmitters come in. That's the chemicals. So imagine, well, I would say this, it's like, well, I was going to try to use Wi-Fi as a metaphor. I don't know how to do that really. We can't approximate the brain as it relates to like computer programming and hardware development because of that level of complexity. And it's that level of complexity, when gone awry, that produces psychiatric illness. So for example, we know that, I'm going to use depression, even though it's kind of controversial right now because of all the research that's come out, but we know that depression is correlated, and probably there's some causation there related to the monoamine neurotransmitter system not working effectively. In other words, serotonin and its receptors, dopamine and norepinephrine and their receptors and transporter systems, and probably more so than all that, glutamate being a problem neurotransmitter system in depression. In other words, you cannot have depression unless those systems are dysfunctional in some way. Now, the treatment for it, from a psychiatry standpoint, they're going to use medication, which we'll talk about in this class. But from our perspective, we are molding a system from the outside in, as compared to psychiatry was from the inside out, which takes a lot longer for its effects. But the good news is that because the frontal lobe is so reliant on the environment, guess what? It's almost impossible for psychiatry to do much for the frontal lobe. But it's almost everything that you do is working with that kiddo's frontal lobe, which is teaching itself, hey, I need to make more dopamine receptors. And which is so cool, because if you treat this stuff in childhood effectively, what we do know is that if you identify it quick and treat it effectively, the brain is less likely to have that dysfunction into adulthood. So another way of saying that would be, do I believe it's possible to cure mental illness during childhood? Absolutely. I think you can literally cure some of these diagnoses in part, or if not in whole, through our form of the treatment and counseling, such that that person who was supposed to have recurring depression the rest of their life, now they won't, because you treated it effectively in childhood. And then even cooler than that, what we know with epigenetics is that you might have modified their genetics in such a way that they're less likely now to genetically pass on depression or whatever it was to their own kids as adults. That's cool. So it's not just like an individual that you're treating, you're also treating possible like generations to come. Y'all heard of the term epigenetics before? Yeah, that's what it is. So it's literally, it's the fact that we've identified, especially for mental illness, there are the genetic predisposition doesn't stay static across generations. It goes up and down depending on the kind of life that person lived. So like if the person lives a chronically stressful life, never has treatment for depression, they're more likely to pass on that depression gene system to their offspring as adults. Even if you've got a genetic history of depression, you're supposed to have it, you get effective treatment for it, you might turn that off or turn it down and subsequently decrease the chance of passing it on to your own offspring. And the most effective time to intervene is when it first happens, which is generally in between pre-adolescence and age 25. That's the spike of all the prevalence rates for every one of these diagnoses. And you are going to be right smack in the middle of that, changing lives. That's the coolest thing ever. It's the most meaningful job you could ever imagine, I promise you. Yeah. All right. I'm going to wrap us up there because I could probably talk and talk and talk for forever, but actually I know I can, not probably. I have before. What questions y'all have about any of this for tonight?
I do. I do get confused between where before we said if there was damage to the physical part, right, that couldn't be reversed. Now we're saying epigenetics. So epigenetics refers more to the neurotransmitters themselves, but that's not considered part of the physical, it's just considered chemical. Is that the difference?
So to kind of explain it, and I see what you're asking, it seems kind of contradictory of what I said, and it kind of is in some degree, but really the idea is that the longer the brain like experiences any symptom, like let's say, well, let's put it this way. If the brain is physically depressed, the longer it stays physically depressed, and the more often it slides into physical depression, which causes psychological depression, the more likely that, or the more that becomes its baseline. Another way of saying it would be like seizure disorders. For example, if you have one seizure, just one, it's not that big a deal. But if you start having like multiple seizures, whatever's causing it needs to be treated quickly because your brain is starting to learn to be more likely to have seizures. And it's the same thing with depression and anxiety or whatever it is. Like the longer your brain is anxious, the more that becomes your average. That becomes your homeostasis, where your brain wants to naturally go. That's why I'm saying it's so important to identify this stuff the quicker you can, because if it's identified sooner and effectively treated sooner, you decrease the likelihood of it becoming the homeostasis, which also in turn changes and modifies the epigenetics. Those systems are built into each other.
Okay.
Because the reverse of epigenetics is also true, by the way. So that the kiddo, let's just say, that never had treatment for depression, now they're adults, their brain, the average is more likely to be depressed. Genetically, since they never had really early treatment, you're not gonna change the epigenetics as much as you would had you had intervened when they were kids. In other words, they're more likely to pass on depression now as adult than they would have been as a kiddo.
Yeah. Thank you.
Hopefully that answers your question.
Yeah,
Sometimes I
it's a
just
lot to
ramble.
process. I may ask you again next week. I'll
Okay,
stick with it.
that's fine.
Thank you.
That's fine. Yep. Any other questions, guys?
I just wanted to say that it's interesting because my friend down the street, just right before class, texted me how her 9-year-old son was just diagnosed with depression and he started Prozac a few weeks ago. It's just so random that she wrote me this. I said, how's that working for him? And she said, he's not crying anymore like he was. And, kind of just, he would just break down all the time, that he wants to be around his family and he's happy and it's working. And it's just interesting now, after hearing what you've said and what we've learned tonight, I feel like I have some positive things I can go back and tell her, like just words of encouragement and hope for him. And I already told her in the text, like, I love how proactive you as parents have been. He's only 9 and they're getting him the help he needs, but it's kind of cool. Some of the things, he has ADHD also. And I'm just like, whoa, 33% of kids can grow out of that. There's a lot of hope here. So it's just kind of cool hearing what you said tonight. I almost wish she was sitting right here listening to this whole lecture, but anyway, that's all I wanted to say.
Every time, like 99% of the time, when I get parents to come in with their kiddos, and this is a good, like, just, I'm just giving you some advice when you work with parents, is remind them that they are ahead of the curve compared to the rest of the parent population out there by helping their kid, because they are literally changing their life and they will never ever see. I mean, not to dismiss how hard it is right now or to dismiss how hard it might be in the future, like just normally, but they'll never see the painful path that their child would have been on had they not tried anything at all. And being a parent's hard because you don't know what the right answer is. And I'm telling you, I teach these classes, and let's just say I definitely don't know what the right answers are. Like, I know a lot of right answers, but they don't always apply neatly as parents. Parents just need to remember that trying is perfection. They're trying, and it's that effort that will completely change their kiddo's life. And that makes me so happy to hear for that kiddo. And I mean, I love, first of all, Prozac, when it's done right and the right diagnosis for kiddos, it works really well. But two is they will have a completely different personality in a healthier way. And I see the product a lot of parents that didn't do it, but they'll never see that. That kiddo is going to be completely on a different trajectory in a good way now because of that.
And cool that you had mentioned about the stigma. And I just think it's really cool that she just texted it in a text.
Yeah.
Like, I mean, there's no stigma there. She's happy that, they found something that's helping them. Yeah. So
Just
anyway,
like it was
just
a
kind
broken
of
arm.
Correlated with this night. Yeah. It's like, he was diagnosed. She said, did I tell you recently that he was diagnosed with depression and started Prozac? Just like, it's just any other sentence. I think that's really cool. And I'm so happy it's helping. So anyway, it just went along with what you were saying. So I wanted to share that.
Well,
thank
you
you
for sharing that. Yeah, that's that makes me happy for that kiddo to have parents and who are with it that much.
Right. Yeah. Now I have another question. So that Prozac fix what's Prozac fixing in that case? Is it fixing? Is it helping get the epigenetics straight, or is it what is it that it's supposed to be helping with?
Prozac's a little bit complicated, but because it is supposed to be a selective serotonin reuptake inhibitor. In other words, it's supposed to primarily increase the brain's ability to use serotonin, which in turn, at least theoretically, is supposed to help your emotional processing center of your brain regulate itself and produce less depressive symptoms. It's more complicated though, because it's probably not, in the case of Prozac, it's probably not the serotonin that it's affecting that's producing its effectiveness to improve mood, improve energy level, improve appetite, decrease cognitive rigidity, all that stuff, decrease anxiety. It's actually the dopamine and norepinephrine that it also influences, which most people don't know about. When you think about Prozac, at least most of us are heard about it or learned about it. It was a selective serotonin reuptake inhibitor. Serotonin was the predominant one, but the dopamine and norepinephrine system is absolutely engaged and modified. And if that's done long enough over a period of time, there's a good chance, especially with kiddos, that they can get off of it and won't need it the rest of their life. As compared to an adult, where it's not that it's impossible that you can't get off of it. It's just that it's probably going to take a lot longer for you to be on it. And the older you are, at the first time that you're trying that form of treatment, and the more you've had a history of untreated depression, the less likely you'll ever be able to get off of it. So it doesn't treat the genetics directly or anything like that. The genetics are changed or modified over time.
Mm-hmm.
It is the time, it's the time of a system being wired in one particular way is what changes genetics. It's not like one specific form of or intervention. It's just literally the indirect result of a system being manipulated over time. Yeah. I do apologize. I'm gonna have to run because my kiddos are about to start our dinner for tonight, but we will get into all the psychopharmacology stuff a lot more in depth, and hopefully in a way that's not too particularly boring. Actually, it's not boring at all. I mean, I'm a little bit biased when I say that, but I try to make it fun and interesting so it's not just me talking the whole time. Well, you guys have a wonderful Christmas and wonderful holiday break. And we will plan on doing this again soon after the new year. There better be flying cars. That's all I'm saying. It's 2023. It's the future. So,
Yeah, right?
Thank you.
all right.
Thank you, and happy holidays.
Thank you. Bye.
Absolutely. Y'all have a great evening.
Thank you.
Take
Bye.
care.